to colorectal cancer. Colorectal cancer is the third most common form of cancer. 9% of cancer deaths are due to colorectal cancer, which is more common in men. Colorectal cancer is diagnosed in about 103,000 Americans every year. The incidence of colorectal cancer in individuals older than 50 is decreasing as a result of increased screening to detect precancerous lesions. The incidence of colon cancer is presented on the next slide. Colorectal cancer has an insidious onset and symptoms do not appear until the disease is advanced. Regular screening is necessary to detect precancerous lesions. Approximately half of all colon cancers occur in the rectosigmoid area. Percentages are listed for males and females. Mortality rates are highest among African American men and women. About 90% of new colorectal cancer cases are detected in people older than 50, and about a third occur in patients with a family history of colorectal cancer. Hereditary non-polyposis colorectal cancer, HNPCC syndrome, also called Lynch syndrome, is the most common inherited form of hereditary colorectal cancer. See the Genetics in Clinical Practice box. Also see Table 4322 for a list of risk factors. Physical exercise and a diet with large amounts of fruits, vegetables, and grains may decrease the risk of colorectal cancer. NSAIDs, such as aspirin, in women may also decrease the risk. Adenocarcinoma is the most common form of colorectal cancer, with 85% arising from adenomatous polyps. The tumor spreads through the walls of the colon into the musculature and into the lymphatic and vascular systems. This is a polyp. This is a picture of cecum and colon carcinomas. Because venous blood leaving the colon and rectum flows through the portal vein and the inferior rectal vein, the liver is commonly a site of metastasis. The cancer spreads from the liver to the two other sites, including the lungs, bone, and brain. Colorectal cancer can also spread directly to adjacent structures. As previously mentioned, there is an insidious onset, and symptoms don't appear until the disease is in advanced stages. These symptoms would include changes in bowel habits, unexplained weight loss, vague abdominal pain, and symptoms of cancer in the left side of the colon appear earlier. Rectal bleeding is the most common symptom of a cancerous lesion. Alternating constipation and diarrhea, changes in stool caliber, sensation of incomplete evacuation, and obstruction. Weakness and fatigue from iron deficiency anemia and occult bleeding occur. Complications include obstruction, bleeding, perforation, peritonitis, and fistula formation. Gio is a 65-year-old man who's admitted for a colon resection following a diagnosis of colorectal cancer. At the time of admission, he complains of constipation, bloody stools, abdominal pain, and weight loss. He's 6 feet 1 inch tall and weighs 200 pounds. He smokes a pack of cigarettes a day. Gio has a history of coronary artery disease and hypertension. He reports taking antihypertensive medication and 81 milligrams of aspirin a day. Gio wants to know how he got colon cancer. What risk factors does he have? That would be age, smoking, and male gender. Symptoms of colorectal cancer are listed on this graphic by location of the primary tumor. Most colorectal cancer arises from adenomatous polyps. Therefore, early detection and removal of precancerous polyps should prevent most colorectal cancer. Beginning at age 50, both men and women at average risk for developing colorectal cancer should undergo screening tests to detect both polyps and cancer according to one of the testing schedules above. CT colonography is also called virtual colonoscopy. Annual screening for cancer includes fecal occult blood testing and fecal immune chemical testing. These are the tests that primarily detect cancer and should be done every year. Only 50% of colorectal cancers are detected by sigmoidoscopy. People at average risk of colorectal cancer should have a colonoscopy every 10 years, beginning at the age of 50, except for African Americans, who should begin having colonoscopy at the age of 45. Those who have the first-degree relative who developed colorectal cancer before the age of 60, or who have two first-degree relatives with colorectal cancer, should have a colonoscopy every 5 years, beginning at age 40, or 10 years earlier than the youngest age at which the relative developed cancer. Individuals at high risk should have a colonoscopy every 5 years, beginning at the age of 40, or 10 years earlier than the youngest age at which a relative developed cancer. Again, colonoscopy and tissue biopsies are needed to confirm a diagnosis. Additional laboratory studies need to be done, such as CBC to check for anemia, coagulation studies, and liver function tests. CT or MRI of the abdomen are helpful diagnostic studies to detect liver metastases, retroperitoneal and pelvic disease, and the depth of penetration of tumor into the bowel wall. Liver function test results may be normal, even when metastasis has occurred. CEA, or carcinoembryonic antigen, is a complex glycoprotein that's sometimes produced by colorectal cancer cells. It can be used to monitor for the disease recurrence after surgery or chemo. It's not a good screening tool because of a large number of false positives. The most commonly used staging system is the TNM staging. This is a depiction of the stages of colorectal cancer. The goals of surgical therapy include complete resection of the tumor together with adequate margins of healthy tissue, a thorough exploration of the abdomen to determine if the cancer has spread, removal of all lymph nodes that drain the area where the cancer is located, restoration of bowel continuity so that normal bowel function will return, and prevention of surgical complications. Some polyps can be removed during colonoscopy, whereas others necessitate surgery. Reduction of colonic bacteria is recommended before surgery to prevent anastomotic leakage of bacteria and decreased postoperative infection and abscess formation. The bowel is typically cleansed with polyethylene glycol lavage solution, that is also called Miralax or Go Lightly, and oral antibiotics given to further decrease the quantities of colonic and renal or rectal bacteria. The site of the colon and colorectal cancer dictates the site of the resection. For example, a right hemicolectomy or a left hemicolectomy. Surgical removal of stage 1 cancer includes removal of the tumor and at least 5 centimeters of intestine on either side of the tumor, plus removal of nearby nodes. The remaining cancer-free ends are sewn back together. Laparoscopic surgery is sometimes used for stage 1 tumors, especially those in the left colon. Low-risk stage 2 tumors are treated with wide resection and reanastomosis, but chemotherapy is used in addition to surgery for high-risk stage 2 tumors. Stage 3 tumors are treated with surgery and chemotherapy. Stage 4 tumors indicates that the cancer has spread to distant sites. Surgery is palliative, chemo is directed at controlling the spread of the cancer, and radiation may be used to provide pain relief. Gio is going to have abdominal surgery for his stage 1 tumor. What's the priority care before surgery? Well, what are his comorbidities? You want to make sure that his hypertension is managed, and regarding his current condition, he needs patient teaching and emotional support. Reasons for a temporary colostomy include perforation, peritonitis, and hemodynamic instability. The ends of the colon can be surgically reconnected at a later time. Most patients with rectal cancer will require an APR or an LAR. The LAR, or low anterior resection, is used most frequently because of the potential for more normal control over defecation. When the tumor is not resectable, or if metastasis is present, palliative surgery is done to control hemorrhage and relieve the malignant bowel obstruction. An LAR may be indicated for tumors of the rectosigmoid and the middle to upper rectum. If the tumor is far enough from the anal sphincters, the sphincters may be left intact. The use of end-to-end anastomosis staplers has allowed lower or less than 5 centimeters from the anus and more secure anastomoses. If the rectum is removed and the anal sphincters remain, the alternative reservoir with either a colonic J pouch or coloplasty can be made. The colonic J pouch is created by folding the distal colon back on itself and suturing it to form a pouch, which will replace the rectum as a reservoir for stool. The patient has a temporary colostomy to allow the J pouch sutures time to heal before stool enters it. Coloplasty is an alternative to the pouch. It is created by slitting the sides of a section of colon a short distance proximal to the anus, stretching the colon transversely to make it wider, and then suturing it closed to a new widened position. Patients with sphincter-sparing procedures may experience diarrhea, constipation, and incontinence even years after the procedure. The colonic J pouch has decreased diarrhea and incontinence problems, but patients may have difficulty evacuating stool. An APR, or abdominal perineal resection, both the tumor and the entire rectum are removed, and the patient has a permanent colostomy. The perineal wound may be closed around a drain or left open with packing to allow healing by granulation. Complications that can occur are delayed wound healing, hemorrhage, persistent perineal sinus tracts, infections, and urinary tract and sexual dysfunction. Chemotherapy is used to shrink the tumor before surgery, as an adjuvant treatment following colon resection for stage 3 and high-risk stage 2 tumors, and as palliative treatment for non-resectable colorectal cancer. Biologic and targeted therapy is also used. 5-fluorouracil, or 5-FU, plus folinic acid is used for chemotherapy. Leucovorin is used alone or in combination with eloxetin or oxaliplatin. Eloxetin is preferred if patients can tolerate the side effects. Oral fluoropyrimidines, Xeloda, have been found equally effective. A drug alert for Xeloda is that patients should be instructed not to get immunizations without a physician's approval, and that they should report a temperature of greater than 100.5 immediately. Gio is very upset. He has many questions about his diagnosis and upcoming surgery. What interventions are appropriate to help alleviate his stress? You should listen to his concerns and questions, talk to him about the procedure and what he can expect following surgery, and elicit information about his support system and encourage him to have those people close by and available during this time. Targeted therapy is used to treat metastatic colorectal cancer. Angiogenesis inhibitors, which inhibit the blood supply to tumors, include bevacizumab, or Avastin, and aflibercept, Zaltrap. Regorafenib, or Sivarga, is a multi-kinase inhibitor that blocks several enzymes that promote cancer growth. Cetuximab, or Erbitux, and panitumumab, Vectibix, block the epidermal growth factor receptor. They're used in the treatment of metastatic colorectal cancer. Chemotherapy and biological and targeted therapy were discussed in detail in Chapter 16. Radiation therapy may be used postoperatively as an adjuvant to surgery and chemo, or as palliative therapy for metastasis to reduce tumor size or to provide symptomatic relief. Your nursing assessment should include a past health history for previous breast or ovarian cancer, familial polyposis, villus adenoma, adenomatous polyps, and inflammatory bowel disease. Subjective and objective data should be obtained from a patient with colorectal cancer, and this is presented in Table 4325. Additional areas of nursing assessment should be medications, weakness or fatigue, change in bowel habits, high calorie, high fat, low fiber diet, increased flatus, and feelings of incomplete evacuation. What does Gio need to know about how smoking can affect his health? Well, smoking actually increases GI motility and may influence his nutrition and dietary regimen and tolerance. He needs to know that this adds risk to his existing cardiovascular condition, and he needs information about smoking cessation. Your nursing diagnoses should include diarrhea or constipation related to altered bowel elimination patterns, fear and anxiety related to diagnosis of colorectal cancer, surgical or therapeutic interventions, and possible terminal illness, and ineffective coping related to diagnosis of cancer and side effects of treatment. There may be others as well, but these are generally present. The overall goals include normal bowel elimination patterns, quality of life appropriate to disease progression, relief of pain, and feelings of comfort and well-being. For health promotion, you want to encourage all persons older than 50 to have regular colorectal cancer screening, help identify those at high risk, participate in early cancer screenings to help decrease mortality rates, and realize that fear and lack of information create barriers to prevention activities. Endoscopic and radiographic procedures can reveal polyps only when the bowel has been adequately prepared to eliminate stool. Provide teaching about bowel cleansing for outpatient diagnostic procedures and directly administer cleansing preparations to inpatients. In general, the patient is placed on a clear liquid diet for 24 to 48 hours before the procedure and is given 4 liters of oral polyethylene glycol (PEG) lavage solution the evening before the procedure. Drinking 2 liters the evening before and 2 liters the morning of the procedure provides better cleansing, especially for endoscopy scheduled for the afternoon. Because many people find the PEG lavage solution difficult to drink and experience nausea and bloating, manufacturers have modified the solutions to improve taste and palatability. Magnesium citrate solution in bisacodyl tablets, otherwise called Dulcolax, are sometimes given before the PEG lavage to remove the bulk of stool so that only 2 liters of PEG is needed. Encourage patients to continue drinking and to drink all of the solution. Stools will be clear or clear yellow liquid when the colon is clean. Acute nursing care for the patient with a colon resection is similar to the care of a patient having a laparotomy, so any sort of abdominal surgery. Patients who have an abdominal perineal resection will have a permanent ostomy and consequently will need intense emotional support. Many patients with colorectal cancer will have immediate reanastomosis of the bowel and will require general postoperative care. Patients with more extensive surgery, such as an APR, may have an open wound and drains, like a Jackson-Prater hemovac, as well as a permanent stoma. If drains are present, they'll remain in place until the drainage is less than 50 milliliters for every 24 hours. Reinforce the dressings and change them frequently during the first several hours post-op, when drainage is likely to be most profuse. Carefully assess all drainage for amount, color, and consistency. The drainage is usually serosanguinous. Examine the wound regularly and record bleeding, excessive drainage, and unusual odor. Use aseptic technique when dressing changes. When changing dressings. If the patient's wound is closed or partially closed, assess the incision for suture integrity and signs and symptoms of wound inflammation and infection. Examine the drainage for color and amount and characteristics. Observe the skin around the drain for signs of inflammation and keep the area around the drain clean and dry. Monitor for edema, erythema, and drainage around the suture line, as well as fever and an elevated white count. The patient may experience phantom rectal sensation because the sympathetic nerves responsible for rectal control are not severed during surgery. The nurse should be astute in distinguishing phantom sensations from perianal abscess pain. Sexual dysfunction is a possible complication of an APR, although the likelihood of sexual dysfunction depends on the surgical technique used. The surgeon should discuss the possibility with the patient. Members of the healthcare team should be available to address the patient's questions and concerns. Erection, ejaculation, and orgasm involve different nerve pathways, and a dysfunction of one does not mean complete sexual dysfunction. What should you teach Gio's wife and family in regard to his postoperative healthcare needs? You should explain to him and them that he will have alterations in his stool and bowel movement. They'll need to know how to take care of his wounds, and they should know new dietary changes and signs to look for in the event of an infection or a future problem. The cancer could return, so patients need much emotional support because recurrent cancer is painful, debilitating, and demoralizing. Issues surrounding palliative care, end-of-life preparation, and hospice need to be addressed. Patients with colostomies need to know how to care for them. Even when patients do not have stomas, they may experience diarrhea, constipation, incontinence, or difficulty passing stool, depending on the section of the colon removed and the surgical procedure performed. Patients need to know about diet, incontinence products, and strategies for managing bloating, diarrhea, and bowel evacuation. It is often a balance of dietary changes and the use of drugs to control diarrhea and constipation. Patients with sphincter-sparing surgery frequently experience diarrhea and incontinence of feces and gas. They often need antidiarrheal drugs or bulking agents to control their diarrhea, but they may overuse them and become constipated. The dietitian should be consulted, and they'll help the patient understand how to choose foods that are less likely to cause diarrhea and odor and could help them discover which foods are problematic for them. As for evaluation, the expected outcomes are minimal alteration of bowel elimination patterns, balanced nutritional intake, relief of pain, quality of life appropriate to the disease progression, and feelings of comfort and well-being. What follow-up care will Geo need once he has healed from his surgery? He'll need regular medical follow-up and screening for the possibility that this problem may recur. He should also know when to be concerned and call his doctor, such as with changes in bowel routine, abdominal pain, or bleeding with stool or from the rectum.